I will now hand it over to Dr. Shed to introduce Dr. Iqbal. Thank you.
Hello, everyone. Thanks for coming today. I'm really looking forward to today's talk. We have Dr. Iqbal here. He is a second-year psychiatry resident in our department here at UNM. He has clinical and research experience with electroconvulsive therapy and will be giving us an introduction to ECT. So I'll go ahead and hand it over and he can get started.
Hello, everyone. Like Dr. Shed said, my name is Sulaiman Iqbal. I'm a second-year resident, and I'll be giving you guys a brief introduction today on ECT, which is short for electroconvulsive therapy. So we'll go ahead and get started. So this is kind of a brief bio, which I think you pretty much know everything it says. I'm a second-year resident at Psychiatry program here at UNM with an interest in ECT. Some CE info for certificates, evals, and attendance. I will leave this up briefly, but not chat too much about it. Okay. And then disclosures, of course, I do not have any financial arrangements related to the content of this presentation. And if I did, I'm not sure if I would say so anyways. So that's what we got. And then another disclaimer, the views expressed in this presentation are mine and not necessarily those of the University of New Mexico. And then our learning objectives for today, well, number one will be to identify the indications for ECT. Number two will be specifying the key components for conducting an informed risk-benefit conversation on ECT with prospective patients. And then the third will be to describe key advances and innovation in ECT moving forward for psychiatric disorders. So ECT, short for electroconvulsive therapy. Why did I choose this topic for this afternoon, or technically this morning? Two main reasons. Number one would be interest, like Dr. Shed mentioned. I was exposed to ECT as a medical student. Thought it was really fascinating and a lot different from a lot of treatment modalities you see both within psychiatry and in other fields of medicine as well. Got the opportunity to do some research with ECT here at UNM with Dr. Abbott. He's one of our attending psychiatrists and has put out a lot of good work on ECT. So that was also helped stimulate my interest in the field. And then relevance, just with constantly increasing demand, I think, for mental health providers, for treatments, and also, being able to have the public be educated about these treatments, and hopefully for all healthcare providers to be aware of what's available and the need for providing these treatments. I think, a talk on ECT, which is one topic that sometimes many, both in and outside the healthcare field, aren't very well versed on, I think is helpful, to go over. So that's kind of why we're talking about ECT today. So brief historical overview of the procedure before we get started. So the idea of using seizures to treat illness goes back to goes back in Europe to at least the 18th century. Specifically, the idea that inducing one illness may be used to treat another illness. By the early 1900s, connections were being made between epilepsy and schizophrenia. Or I should say the inverse connection. Basically, patients who did suffer from epilepsy seem to have decreased incidence of psychotic episodes. This was kind of subjectively observed. And then by the 1930s in Italy, I believe, the first electrical induced seizure was used to treat an episode of psychosis. And after that, the practice kind of gained some repute and spread across Europe and into America. Starts pretty strong. People are, interested in having a new treatment modality that can treat a lot of these psychiatric disorders. Back in the 50s, 60s, there's not a whole lot of options. So people were excited that there was something new coming that seemed to have some efficacy. It starts to lose steam, around the 70s due to a couple reasons. One is not great messaging from healthcare providers about what this procedure really does, what are its risks, what are its benefits. You start to get kind of negative perceptions about ECT. That's, some stereotypes you might be familiar with now, people, being shut away in this cold dungeon and being shocked, numerous times. So there's definitely some issues with messaging and then public, reception of the practice. Better education, better treatment standards and standardization, making the procedure as safe and well tolerated as possible, contributes to the practice started growing again in the 80s and 90s, to the point where I think we are now, whereas, procedures regarded pretty highly in, healthcare professional circles, but still underutilized due to a variety of reasons. One of them could still be lingering public, hesitancy about the procedure, other non-psychiatrists being really unclear about what the procedure is for and what it does. And then, of course, access is always the biggest thing. Do hospitals offer it? Are there trained psychiatrists who can provide it, and will insurance cover it? So that's where I think we're at right now. So how does ECT work? Basically, ECT is about generating an electrical current that will stimulate a seizure in a patient, which is thought to affect a therapeutic effect that will help treat a severe acute psychiatric illness. This is, the exact mechanism of action is not 100% understood, but it's thought to be, one of two things at least. One of them could be the release of neurotransmitters and hormones. These could be things like dopamine, norepinephrine, serotonin that we often use in our medications to target psychiatric illness. It could be hormones related with pituitary, things like TSH, ACTH, thyroid, cortisol stimulating hormone, things like that, that are thought to have a therapeutic effect. Another area where it's thought to be helpful is increased neuroplasticity in the brain. So that works in two ways. One of them is physically, ECT leading to architectural change in the brain. And then another way that it affects neuroplasticity is just actually increasing the brain's ability to form new connections. Both of these effects thought to be helpful in treating acute psychiatric illness. Okay, so the procedure itself. So you have a patient who you think needs to go ECT. The first step is to clear him medically. There are no common absolute contraindications to ECT, but there are relative contraindications, things you would think about any patient who has to undergo a procedure under anesthesia, if he has quite bad heart function, if there's an issue with concern for brain masses, things like that. So usually there's no issue clearing patients medically, but if there ever is a concern, just, we'll consult a specialist in that field that we have the area of concern for to see if it's safe. The night of and the morning before you will, the night before and the morning of, you will hold anti-epileptics. So medications that will make it harder for a patient to get a seizure, which is what we're trying to induce. The most typical medications these end up being will be benzos. In psychiatric patients, they're one of the first line meds that patients are often on for agitation, anxiety. So just, it's always important communicating with healthcare staff, the nursing team, everyone that, the night before and the morning of, no benzos for patients. There's been a number of, planned ECT sessions that have been thwarted due to this not being properly communicated or, carried out by teams. So it's always important to make sure to hold the benzos. What 1 milligram, a few hours before isn't gonna sink the whole thing, but still important to make sure we get the best ECT treatment possible. So once that's that's all lined up, patient will be brought to a procedure suite, typically with a psychiatrist, an anesthesiologist, and a nurse present. They'll basically just let them know we're starting ECT. Usually patients will know what number of treatment they're on. If not, you can remind them, hey, we're on number 2, we're on number 3. Again, if patients are hesitant, going over again a quick risk benefit and what's expected today. And patients are pretty comfortable with that usually. And then once you're ready to get started, they'll be administered an anesthetic, something like propofol. I've seen ketamine used, and a muscle relaxant, something like acetylcholine. And these are basically just to make sure the procedure is as comfortable and as well tolerated as possible for the patient. Patients are a lot more likely to have a safe procedure and want to come back for more if they're not awake, thrashing around, hitting their arms against things during the procedure. So the anesthesia definitely makes it safer and more comfortable, I think, for everyone. And so what you'll do is you'll have an ECT, like a machine or a unit in there where you'll be able to dial in the settings you want for your patient. And then once, the timeout's been done, everything, the anesthesia's working, everything's good to go, you'll basically, there's a button you can click that will deliver an electric charge via, through the electrodes that are placed on a patient's head, either bitemporally or unilaterally. And basically, when you press that button, you'll basically say like delivering charge or shock now. I tend to say energized just because I like the way that sounds. Seizure will be induced. You'll monitor it both from a motor standpoint, so you can physically see the patient starting to shake, indicating the seizure is going. You'll also often have EEG monitoring, so a couple of leads where you can actually see if the patient is seizing. Sometimes helpful because the physical symptoms of the seizure aren't always reliable, especially once they have anesthesia on board. And you'll get a good sense from that of when the seizure starts. Is it a good seizure as far as seizure morphology from the EEG, and a good sense of when it stops. Usually you can expect the induced seizure to last between 30 and 70 seconds before spontaneously resolving. So a very short procedure. The longest part's basically wheeling them down to the room, checking off all the boxes, making sure everything's safe. But usually within a minute, the seizure is resolved. Anesthesia will help bring the patient to again, and within a couple of minutes, they'll be awake and grossly know what's going on. It's common to be a bit confused about, what exactly is going on, but that usually spontaneously resolves within the hour. So pretty soon after the patient's, alert and oriented and kind of, participate in interactions to know what's going on. Still not a good idea for them to drive, obviously the same day, but pretty good rebound time. This is kind of like what you would expect to see in a procedure room with ECT. So you have your anesthesiologist, you have the patient, you have your psychiatrist. ECT is usually pretty well tolerated, and we don't really have issues in the procedure room when patients are brought down. But I have never seen a patient this happy either before or after ECT. So this could be like a simulated picture or something as an advertisement, but just pointing that out. And then I touched briefly on the placement of electrodes on the patient's head, where the electric current will be delivered from the ECT machine to the patient. And so there's a couple of different positionings that can be used. So here's kind of a depiction. Bilateral, that first image, so you'll have basically one on the temple on the left, one on the temple on the right. Next is right unilateral. As you can see, both electrodes are kind of on the right side of the patient's head. And then bifrontal is one where you don't really see this one as commonly as the above two, but it's basically on the front skull, front lobe area of the patient. Okay, so treatment and follow-up. So basically what you're doing is once a patient's been decided they're going to undergo an ECT course, specifically for more chronic things like depression, schizophrenia, you'll have treatment occur 3 days a week. Usually it'll be like a Monday, Wednesday, Friday, Tuesday, Thursday, Saturday schedule. Sessions will typically be at least somewhere between 6 and 12 total treatments during the main treatment course. Could be shorter, could be longer, depending on the patient's response. If sometimes you'll have what they call like maintenance sessions, which will be spaced at wider intervals after the initial treatment course of like the 6 to 12 and 3 days a week. Maybe you'll do 1 day a week for a while to kind of titrate the patient off ECT. Important to remember as well that during their active treatment sessions, during this 6 to 12 session period, and afterwards, once they're done with ECT, to continue oral meds, because those will be important for ensuring you get like the most efficacious response to treatment. And studies have shown patients that are on oral meds, whether it's for schizophrenia, depression, at the same time as getting ECT, tend to do better. So important to continue those and not trying to rely just on ECT. Okay, so who gets ECT? Who is typically referred for ECT? So typically what you will see is patients who have treatment resistance or like very acute, severe presentations of depression, psychosis, or bipolar disorders. Often you will also see used for things like catatonia, pregnant patients who are very acute in the sense that maybe they are not wanting to eat or drink, and so they're starting to pose like an acute sense of risk to their own health in the short term. Maybe they're very, very suicidal, even in a usually safe setting that's hard to ensure their safety. So these are the type of patients you'll see often that psychiatrists think are appropriate candidates for ECT. And something you'll often see is, since they're treatment resistant, the question is like how many, like what treatment resistant in what sense? Do they need to have tried oral meds before? Do they need to have failed them? There's no hard and fast number that's like, absolutely required in terms of they need to have failed X amount of medications before trying ECT. Some number you'll often see kind of just casually said is like 2. So, sometimes if patients have tried, like say they're very depressed and suicidal, if they've been on one class of antidepressant, another class of antidepressant, both with, adequate trials and haven't responded, you'll see patients or providers start to think patients would benefit from ECT. But that is not required. Generally what I would recommend, and what I think many psychiatrists recommend, is to let like the patient's presentation, how acute they are, how much of a danger to themselves they are to, in terms of suicidality, in terms of, catatonia, whatever it may be, to let that drive your decision making. So let the patient's presentation and how acute they are let you decide if, you think they'd be appropriate for ECT. Okay, so what are the benefits of the procedure? So one of the main ones is the patient response. Usually you'll get a response to ECT within 1 to 2 weeks. For comparison, a lot of the meds we use to treat these acute psychiatric disorders can sometimes take anywhere between like 2 and 6 weeks to start seeing significant response. So ECT definitely provides a faster response rate for, just so everyone knows, like 1 to 2 weeks of ECT treatments is only about anywhere between 3 to 5 treatments. So definitely a lot quicker response than, using meds. High response rate, depending on the study, anywhere from 50 to 90% will respond to ECT, which given the patient population this is typically used in, treatment resistant patients, very acute patients, is a pretty good response rate. Definitely something we would take. Oops, another benefit, well tolerated without, significant risk of a major adverse event. Usually most of the major adverse things are basically related to the anesthesia rather than the ECT itself. And again, that's a very low risk of something major happening. Another benefits can be preferred option in patient populations where, side effects of medications or contraindications make traditional medications less advisable. So this could be pregnant patients, this could be elderly patients, patients with certain metabolic or metabolizing issues. So definitely robust in that sense, and that's something a lot of providers, a lot of patients don't realize at the outset. So what are the drawbacks? So by far the most common, the one most associated with ECT you'll hear are the mild cognitive impairments. And when we say cognitive impairments, we usually mean deficits in memory, verbal fluency, things like that. Relatively common after treatment. Not everyone has it, but based on the studies, you see incidents anywhere from like 30%, 70%. So common enough that everyone needs to be kind of, aware of the possible side effects. The severity is really dependent on a number of factors. For example, the number of treatments. If you've had more treatments, you're more likely to have to experience symptoms and, more significant symptoms in terms of intensity. The type of treatment. So as we touched on earlier, there's different ways you can do ECT as far as where the electrodes are placed on your head. So right unilateral, when electrodes, like say on the right side of your head, tends to be easier on patients as far as experiencing these cognitive impairments afterwards. Bitemporal seems to be a little bit harsher. But there's often a trade-off in terms of efficacy. Sometimes when you give up like the strength of the response in terms of whether you want to give them a stronger electrical current or stimulate to both sides of the heads, sometimes you may get less adverse cognitive side effects, but you may give up more efficacious, like say antidepressant response. So that's always something to think about and will affect, what type of settings they'll use. And also baseline cognition, patients with lower baseline cognition will tend to have worse effects in cognitive impairment after ECT. something that is helpful to do, and I think they're doing more, is just using like standardized cognition tests before ECT to get a sense of what is the patient's baseline, so you know just how affected they are after the treatment, and can monitor them for improvement, you know, in the weeks or months afterwards. And then psychiatric disease burden at baseline also is something that that affects the cognitive impairment. So the reassuring thing is this cognitive impairment is usually mild to moderate symptoms, and most or all often adverse symptoms will resolve within a few weeks to months after your final treatment. So definitely something we talk to patients about, is let them know that, you know, if you do experience these adverse symptoms, it's not something you're going to be hobbled with for life. So to keep that in mind. And so, you know, on balance, when people, you know, think about the risks versus benefits, most patients and providers agree that the benefits of ECT far outweigh the risks. On one hand, you're getting a fast, efficacious, pretty safe response to treating, you know, very highly acute treatment-resistant psychiatric illness, and the mild to moderate adverse cognitive symptoms are typically fairly manageable and will, you know, self-resolve within a few weeks to months after treatment. So most patients and providers think that's a pretty good trade-off. And as we touched on earlier, I think the stigma, as far as, you know, the safety, the optics of ECT is starting to resolve as, you know, better education and messaging is put out there to the public. I think the greatest, you know, hurdles to treatment going forward, and I think that I've experienced personally, are do hospitals offer the procedure? Are there trained psychiatrists who can perform it, and the insurance coverage? I know at UNM, I've heard about one patient that we transferred to us from a neighboring state who was very acute psychiatrically. I think he might have had catatonia, and they weren't, you know, responsive to initial treatment where they were at. I think initially they were using like benzo medication. So ECT was indicated, but for whatever reason, they couldn't get it where they were at. So they had to transfer to UNM where they got the treatment, and they rebounded quickly. So that's kind of a real life example of, you know, how issues with availability can have patients to travel, you know, to certain areas to get the treatment, which again, once they receive it, pretty efficacious and pretty safe. So future of ECT, where is the field going? So there's, as far as, you know, I think ECT is one of those fields where there's like a robust research arena. There's a lot of research going on in terms of trying to make it more efficacious, try to understand the mechanism of action. So in that sense, it's a good field, I think, to be conducting research in. Some of the research I've read about and have participated in, some of it explores how the variables, different variables or the ECT parameters we use, things like amplitude, pulse width, electrode placement, which I touched on earlier, can interact with treatment efficacy versus cognitive side effects. So for example, I put out a paper with Dr. Abbott 2 years ago, I believe, where we looked at amplitudes. So for example, commonly used ones would be like 600, 700, 800. And, you know, examine how those using different amplitudes on patients will affect how well they respond in terms of their depression decreasing, but also how is that, you know, related to adverse cognitive effects. So for example, 800 milliamps may, you know, delivers a stronger magnitude of charge. We'll see a more robust improvement in patients' depression, but is also like associated with more adverse cognitive effects. Whereas the reverse may be found for, like, say, 600, where the antidepressant improvement's not as good, but they also experience less cognitive effects. And you can see the same thing with parameters like pulse width, where you'll find like ultra brief versus brief will have different effects on depression response versus cognitive adverse effects. And as I mentioned earlier, the electrode placement will affect it as well. So really being able to tease out what seems to impact, you know, treatment response versus side effects in terms of each parameter is very helpful. And I think something the research is moving towards. Another interesting thing is something called E-field research. Well, they'll look at the generated electrical field in the brain from a seizure and look at how that electrical field, or E-field, is related to patient response in terms of treatment efficacy and adverse cognitive effects. The idea here would be that the electrical field, rather than the seizure itself, is like the most important thing in, you know, seeing how a patient will respond. So rather than using like a fixed scale of dosing for every patient, which is what's often done, which, you know, depending on the patient, depending, you know, on their specific parameters, maybe over or under dosing the electrical charge, leading to suboptimal responses. You can try pre-treatment evaluation to assess, what are the parameters you need to cause the appropriate E field. And this could be like pre-treatment, like MRIs, to get a sense of brain architecture. Obviously, that would be tough to do for every patient. So something else they started doing is considering like dose titration. So adjusting parameters incrementally based on patient response and based on the E field you're stimulating to get your target E field in the brain that you think is like the sweet spot for, say, treatment response and minimizing adverse cognitive effects. So that's an interesting place I think the field is moving to in the future. Still need, I think, a better sense of where in the brain the E field is most correlated with treatment response, and trying to tie the location of E field to like specific brain architecture, as far as like the hypothalamus, certain areas in the brain that you think may be affecting cognition or depression. But I definitely think in the future you'll see a lot more tailored ECT parameters to specific patients based on possibly trying to get your ideal E field rather than just trying to stimulate seizure. And that is my overview. I think we hit all of our learning objectives. If anyone has questions, comments, critiques, I didn't put this on there, but compliments are welcome as well. So any of that at this time would be appropriate.
I definitely have a compliment, definitely demystified ECT a bit. And I have a question, or maybe you could just speak to this, because oftentimes patients are really severely ill and aren't able to give consent. So if you could kind of speak to that process about how we ensure that their rights are protected, because historically this procedure has been kind of weaponized against deviant behavior, and that's part of the reason it's so stigmatized. And we, as a discipline, have kind of moved away from that.
Yeah, that's definitely a good question. So we knowing the risk and benefits and having these conversations with patients, as far as making sure they understand what they're getting into or not getting into, is important. But like Dr. Shed mentions, the reason these patients are often getting these treatments is exactly because they're very psychiatrically acute. And in these settings, patients often don't have the capacity to consent or, dissent from ECT. In those situations, like in my own personal experience, we'll rely on treatment guardians or patients, or basically surrogate decision makers. These could be like appointed family members, friends, professional treatment guardians that work with the state that essentially help make these medical decisions with the patient when the patient themselves alone aren't able to like really appropriately appreciate the risks and the benefits. So yeah, it's definitely, I think it's definitely important to emphasize that when there's a concern patients don't really appreciate the risks and the benefits and what's being offered, that there's like a second level of decision makers and people who are kind of appraised of what is being proposed, rather than doctors kind of unilaterally making the decision for the patients and forcing them into this procedure or any procedure, whether it's forcing long-term meds or forcing ECT. So yeah, definitely I think important to bring up. No more questions, no comments. Yeah, don't feel pressured. I know, like, I've been on the receiving end of lots of Zoom lectures, and sometimes people ask for questions and comments, and I'm just like, oh, I don't want to leave them hanging, but I'm just, not in the mood. So don't feel pressured to say something if you don't want to.
I have another question. I'm just wondering, in your practice, if you've treated a lot of pregnant women, and kind of speak more to that, because that's a particularly vulnerable population. I think it speaks to how safe ECT is, but if you have any experience and what your thoughts are about that.
Sure. I have treated exactly 0 pregnant patients. It is not super common to get those patients where they're very acute and pregnant. I think as far as like treatment parameters, everything go, it's more or less the same. There may be like adjustments to like the anesthesia they use depending if the patient's pregnant or not. And I think usually it's recommended that if pregnant patients get ECT, it should be hopefully with someone who has some familiarity or experience administering ECT to pregnant patients, and obviously like an anesthesiologist who has experience with pregnant patients. But I personally have never had the opportunity to like have that discussion with the pregnant patient or refer them or be the one helping to treat them during ECT. But I mean, I definitely think it would be an interesting situation, because I know like when I first heard about it, that sounds like the last thing you would expect a pregnant person to like be safe getting as ECT, but it turns out to be safer even than many like meds we offer for acute psychiatric illness in pregnant patients. So definitely something that should be less towards the back of our minds in terms of like acute treatment for, you know, psychiatric illness in pregnant patients, and, you know, closer towards the front. Something interesting is that, you know, when you talk to patients about the benefits of ECT, the risks, they often, a lot of them will be like, hey, you know, ECT actually sounds better than even starting with meds. And sometimes they'll be interested in being like, all right, forget all the med trials, forget trying to treat this kind of what we would consider conservatively, right, with, you know, 4 to 6 weeks of meds first. They're like, can we just do straight ECT? And I think that that's an interesting thing. I wonder in the future if it'll be more acceptable to consider ECT as like first line in patients who may not be super acute, as we talked about earlier, but are, you know, certainly suffering from illness and kind of want to skip the med trial phase. I think the biggest issue to that will be, number one, like cost and availability. I don't know if insurance will cover patients getting ECT as first line for like non, you know, indicated, you know, treatment resistant or very acute presentations. That's definitely something I've thought about when talking about ECT, you know, and like versus meds and all that kind of stuff with patients. No other questions, no other concerns. I'll take your silence as a compliment that I've left you all speechless. These are some of the references I used, a couple of papers, one of them with Dr. Abbott on them. And then there's actually, if you go to UpToDate, there's good like patient info pages that you can print out. That'll be like very basic information, like at a patient level for them to understand. And also good forms that kind of you can use as like a risk benefit kind of sheet to give patients, give family members, that kind of very cleanly lays out like things patients need to know, things they need to be aware of before consenting to or dissenting from the procedure. And then here's a QR code or something that I'm forced to have at the end of this presentation. Okay, and that's it, everyone. Thank you for tuning in for this brief intro.